Welcome to this clinical masterclass on the pharmacological management of inflammation in orthopedics, based on the research and frameworks provided by Assistant Professor Dr. Farhad Mustafa Musa Atrushi. Every day, orthopedic practitioners face a baseline challenge. A patient presents with severe, localized inflammation and requires immediate pharmacological relief. Relieving that pain inherently requires disrupting normal biological processes. The same inflammatory mediators responsible for patient discomfort are also critical signals for cellular repair. Standard anti-inflammatory agents actively suppress the specific pathways required to heal a fracture and maintain long-term bone density. By mapping these molecular cascades and charting the specific impacts of corticosteroids, we can derive a rigid, risk-stratified prescribing algorithm. Ultimately, orthopedic success depends entirely on balancing patient comfort against the mechanical and physiological integrity of the skeleton. To understand exactly how these drugs interact with bone tissue, we have to look past the joint and examine the reactions at the microscopic level. This arachidonic acid cascade flowchart dictates the baseline of human inflammation. The flow begins with membrane phospholipids and ends producing crucial signaling molecules, prostaglandins and thromboxane A2. NSAIDs exert their primary effect by severing this entire pathway precisely at the COX enzyme node. This diagram compares lock-and-key mechanisms of nonspecific inhibitors. Aspirin forms an irreversible covalent bind to the COX enzyme, completely halting platelet aggregation for over a week. By contrast, ibuprofen acts as a reversible competitive inhibitor. It temporarily occupies the active site, its effects dissipating quickly. This endoscopic view and diagram illustrate the clinical toll of indiscriminate blockade. Shutting down COX-1 removes the stomach's protective mucus shield. Chronic users face a measurable 2 to 4% incidence of peptic ulcer perforations, severe bleeding, or obstructions. This risk escalates in older patients and those with GI disorders, but concurrent anticoagulant use remains the most critical factor for life-threatening complications. The physiological trade-off of nonspecific NSAIDs is simple. Achieving pain relief via indiscriminate blockade comes directly at the cost of the patient's gastrointestinal defense system. This slide details the pharmaceutical industry's specific answer to that GI toll: COX-2 specific inhibitors. By specifically bypassing the COX-1 enzyme, these drugs maintain gastric mucosa integrity and preserve essential platelet function. The key agent utilized in this class is selexicop. Looking at this three-step diagram, we see why these drugs, while GI safe, introduce a devastating orthopedic complication by disrupting callus formation. Normally, mesenchymal stem cells gather at the fracture gap. Here is the mechanism of failure. The absence of COX-2 actively halts stem cells from undergoing chondrogenic differentiation. Endochondral ossification is severely stunted, and the bone simply stops bridging the gap. Clinically, delayed union and non-union risks increase significantly in adult patients facing large doses or prolonged use. This clinical decision matrix compares traits side by side. Practitioners must weigh the preserved gastric mucosa offered by COX-2s directly against their high risk of delayed secondary bone union. Crucially, neither drug class provides superior efficacy for standard osteoarthritis. Their pain-relieving capabilities are equivalent. This creates a direct clinical paradox. Maximizing systemic safety with COX-2 inhibitors actively sabotages the local orthopedic goal of fracture union. This graph plots the skeletal risks of the next major anti-inflammatory class, systemic corticosteroids. The toxicity timeline shows severe bone mineral density loss accelerating rapidly past the 3-month mark. The dose trigger is extremely low. Daily doses of just 2.5 to 5.0 milligrams cause structural degradation. This necessitates a mandatory high-risk protocol, initiating prophylactic bisphosphonate therapy to prevent iatrogenic fractures in chronic users. The route of administration drastically alters this skeletal risk profile. Epidural injections are directly associated with a measurable loss of lumbar bone mineral density. However, intra-articular injections in large joints like the knee avoid systemic density loss, though they carry localized side effects. Corticosteroid administration is inherently catabolic to the skeleton, requiring proactive physiological defense when used chronically. This flowchart synthesizes all previous biochemical constraints into a single, rigid orthopedic prescribing algorithm. First, if the patient is actively healing a fracture, COX-2-specific inhibitors must be avoided entirely to preserve endochondral ossification. Second, if the patient has a high GI ulcer risk or uses concurrent anticoagulants, COX-2 specifics are mandatory over nonspecific NSAIDs. Third, if the patient is perioperative, COX-2 inhibitors are indicated precisely because they preserve essential platelet function. Finally, if prolonged systemic steroids are necessary, concurrent bisphosphonate therapy must be initiated immediately. Integrity of the skeleton from the treatment itself. Thanks so much to Assistant Professor Dr. Farhad Mustafa Musa Atrushi for providing the clinical frameworks and data that made this